I was just thinking, we think about physicians and nurse practitioners and PAs, but really people are seeking out health care in so many ways other than the clinical site and in the doctor's office. And I'm just wondering if anybody, either the panelists, want to talk about how do we address all the needs that patients are looking for, and what does that team in the community even look like?
I think one of the really nifty experiments we've had at Methodist Hospital is using our the fire department, and they realized that a very high percentage of their calls were not to put out fires, but they were to help see people in their home and then get them into the hospital. And so and I wish I could tell you all the metrics and how this has worked, but for the last several years, we've teamed with the local fire department to do home visits after patients have been discharged. And what I've been particularly, they do the obvious things, check in on them. How are they looking? What are their vital signs like? Do they know their medicines? How about those other 40 bottles that are in the medicine cabinet that they're getting confused with? They also do things like looking for carbon monoxide and smoke detectors, looking for fall risk issues in the home, and all these other things, these other determinants of, and I think it's a great example of what you're talking about, trying to link with the community to develop more of a holistic approach.
That's fascinating. How do you pay for that?
Well, there we go again, isn't it?
So there is the community paramedic program that is getting some reimbursement from Medicare. So it's keeping people out of the hospital. And I know there's different programs that are out there. Does anybody else want to comment?
Yeah, the firemen get paid anyway. They're on duty, so they get paid, okay? And they're doing it during the day when they get paid. So it's actually better use of the fire department personnel to actually get them out in the community. That's how it's getting paid for. And it saves the fire department money because they have to pay people. A lot of them are volunteer departments, and they have to pay them to come out at night to do that 2 o'clock in the morning visit because I fell down and I can't get up. So that's how it started in St. Louis Park. The chief was trying to decrease his night calls and said, why can't we do it during the day when I got people here? The paramedics in the rural area, and there is actually, the state's setting up a payment system for that because I was on that committee, and that's coming forward from the legislature now. So, and that's actually to pay paramedics to make basically home visits instead of a nurse home visit. They would get a paramedic because in the rural areas, especially, the amount of home care isn't available, so they're going to use paramedics for that are already out there.
The record here, that's Jeremy Springer talking, who's the head of the Creekside Family Medicine Training Program. And Jeremy, since you know so much more about the fire department program, is there anything else you'd like to add?
It now involves, I think, 4 or 5 programs. Minneapolis actually got a grant to put up fire smoke and carbon monoxide detectors. Some of the suburban programs don't do that. It's spreading across the country now. When the local chiefs go to national meetings, they're getting a big interest in Colorado and New York and everywhere else. So it's really spreading around a lot. But it actually came to fruition in Minnesota, so it's kind of a local grown product.
I still remember when my brother-in-law went to practice, this was like 50 years ago, and if somebody disagreed with him and what he recommended, he said, well, obviously you don't trust me, maybe you should find another doctor. We used to do things to patients, and then we did things for patients, and now we're learning to do things with patients. And one of the things that's been interesting is we've tried at times to pull patients into our work groups when we're setting up new workflows or new processes. And there's a lot of skepticism from a lot of our clinician and other members, but I still remember somebody saying, I thought this was so stupid, and then you brought that patient in, boy, did I learn a lot from him. And so I think part of our future is listening more, because we're one of the few industries that doesn't yet do a good job of that.